All right. Good afternoon, everyone. Welcome to National Public Health Week, Day 3. We're excited today to present Dr. Melissa Stevens. I'm Don Simpson, the program director for the MPH program at the Arkansas Colleges of Health Education, and it's a privilege to be a part and help facilitate this session today. So we're going to do a couple things. I'm going to read a land acknowledgement, and then I'll introduce our speaker and turn it over to her. We are on the unceded homelands of Native peoples who have ongoing cultural and spiritual connections to the places we live. We acknowledge and send gratitude to the land and to the people who have stewarded it through the generations. In acknowledging this history, we do not intend a superficial action that somehow releases us from the obligations of righting past wrongs. We acknowledge that we live in a world where privileged peoples have gained wealth by colonizing, enslaving, and oppressing other peoples and communities. We see the ongoing effects of these practices and policies every day, and we work to be accountable to our part in this history. We each come from a different history. We have each lived a unique life. We bring those experiences to the work we do today. We affirm and celebrate our commitment to the difficult and joyous work we must do to transform our communities into ones built on justice and on caring for each other and our lands. It's my pleasure to introduce Dr. Stevens. Dr. Melissa Stevens graduated with distinction from the University of Missouri, Kansas City School of Medicine in 1998. She completed family medicine residency training at the University of Kansas Medical Center in 2001. After residence, she remained on faculty for 1 year as an assistant professor in the Department of Family Medicine. Dr. Stevens then spent more than a decade in clinical practice caring for underserved patients in academic, rural, and urban settings in the Midwest, Pacific Northwest, and Mississippi Gulf Coast. In 2015, Dr. Stevens joined the William Carey University College of Osteopathic Medicine in Hattiesburg, Mississippi, as Associate Professor of Clinical Sciences. During her tenure as a full-time faculty member at the medical school, she was promoted to Professor of Clinical Sciences and Associate Dean of Primary Care and Graduate Medical Education. In July 2023, Dr. Stevens transitioned to a part-time position as Associate Dean of Population Health. Dr. Stevens made this transition to accept a position as the Associate Program Director of the EC HealthNet Family Medicine Residency Program in Meridian, Mississippi. She was promoted to Program Director of the Community-Based Rural Residency Program in January 2024. Dr. Stevens worked closely with strategic partners to help the residency program launch the first rural maternal health family medicine with obstetrics fellowship in Mississippi in September of 2024. On New Year's Eve of 2024, my wife and I had the privilege of meeting Dr. Stevens and her husband, John, as they were relocating to Arkansas so she could serve as Assistant Dean of Clinical Medicine and Professor of Family Medicine at the Arkansas College of Osteopathic Medicine. In this role, she supports not only undergraduate medical education at the medical school, but also is sponsored and affiliated graduate medical education programs. Dr. Stevens has received numerous honors and awards and is a diplomat of the American Board of Family Medicine and a fellow of the American Academy of Family Physicians. It's a pleasure to welcome Dr. Stevens and introduce her as she presents Seeking Solutions for the Maternal Health Crisis in Arkansas. As she presents, if you have questions, please pop them in the chat and we'll make sure she has a chance to answer them following her presentation. Dr. Stevens?
Thank you. It's a pleasure to be with you all today. And I'm very excited to talk about this topic, which is near and dear to my heart. So as way of disclosures, I have no disclosures, nor do any of the other planning members that I am aware of with any ineligible companies. And so also we want to acknowledge that there's been no commercial support for this particular activity. So my learning objectives today, I tried to keep quite simple. And so I plan to discuss some of the risk factors that contribute to the maternal health crisis here in Arkansas, as well as help everyone have a better understanding of the epidemiology of the maternal morbidity and mortality crisis that we have going on in Arkansas. And then at the end, kind of conclude by outlining some possible solutions that can help improve maternal health outcomes in the state. So I wanted to start just by having a discussion about maternal health risk factors. And so we know there's a variety of things that can affect a woman as she enters into a pregnancy that can increase her risk of a poor outcome. And so I put them into kind of four major categories, and we're going to talk about each one in a little bit more depth. But the first is existing health conditions, things that she has prior to the pregnancy. Then it's health issues that can happen before or during the pregnancy. And then certainly the mother's age, as well as lifestyle factors. So when we talk about these risk factors, existing health conditions, some of the best known risks that we know for women entering pregnancy are things like hypertension, diabetes, obesity, kidney disease, and all of those things. Unfortunately, women here in the state of Arkansas um, have at a significantly higher prevalence than a lot of other women in the United States. So if we look at the rankings for Arkansas in particular, Arkansas ranks number 45 for hypertension, 42 for diabetes, 45 for obesity, and 42 for kidney disease, which of course many of these conditions are interrelated, but it's suggesting that women here are impacted significantly more frequently than others. This is one of those things where we'd like to be at the top with the lowest prevalence, but unfortunately we rank at the high end of the scale with the most prevalence. We also know that there's other underlying health conditions that can adversely affect pregnancy. So things like polycystic ovarian syndrome, a variety of different autoimmune diseases, as well as thyroid disease. And of course, something that's really come to the forefront of a lot of our thoughts with the pandemic that we have just worked our way through are some of the infectious diseases. And so COVID-19 certainly had a very negative impact on a lot of women in their pregnancy and the outcomes that we were seeing. But things like HIV and AIDS certainly have over the years, as well as Zika infection and other infectious agents. We know that there's also health issues that can happen before or during the pregnancy that can have an adverse effect on outcome. So women that have multiple gestations, and so if they're pregnant with twins or triplets or more, that can certainly lead to poor outcomes. The presence of gestational diabetes or preeclampsia or eclampsia with elevation in their blood pressures and all of the sequelae that go along with that in pregnancy. We know that congenital anomalies or genetic conditions in the fetus can also lead to poor outcomes. And then having a history of previous preterm birth, which the statistics that I have here for you are the statistics that come from the March of Dimes related to preterm births here in the state of Arkansas. So you can see here that there are some fairly significant disparities with our Black mothers having the highest rate of preterm births at 16.6%. Followed by Pacific Islanders at 13.7%, and then American Indians and Alaska Natives at 11.5%, and then white mothers at 11%, Hispanic mothers at 10.1%, and Asian mothers at 9.7%. We know a mother's age can also have a significant impact on her pregnancy, and so we see that the most impact when we see women at both ends of the age spectrum. So very young women or pregnant teens can see significantly worse outcomes, as can women that are experiencing a first-time pregnancy after the age of 5. And then, of course, lifestyle factors, I think, is probably no surprise to most, but the use of alcohol, tobacco, or other illicit drugs during the pregnancy is known to have a negative impact. So let's talk a little bit about the epidemiology of maternal health and morbidity and mortality here in the state of Arkansas. So I always like to start with kind of a big overall picture. And so the Commonwealth Fund State Scorecard on Women's Health and Reproductive Care really looks at maternal mortality rates in the entire United States. And one of the things that we've seen through their research is that here in the US, our maternal mortality rates are higher than other high-income countries. So based upon their research, we've seen really that there are several drivers for this U.S. maternal mortality. One of the first is inadequate access to healthcare services, and that can be before pregnancy. So in the phase where we're trying to do preconceptual counseling, certainly during the pregnancy, and then after the pregnancy during the window of postpartum care. And we know that there's a lot of things that can impact that. So some of the barriers are things such as just access due to reduced transportation or limits in childcare where the women aren't able to get into the doctor to seek the care that they need. We also know that there are disparities in socioeconomic status as well as disparities in underlying health and quality of care that have negative effects. So if you look at the Commonwealth Fund state scorecard statistics on specifically maternal mortality rate, the states here with the darkest shade of blue have the highest number of maternal deaths per 100,000 live births. So of all of the states, the highest rates of maternal mortality in the United States are found in the Mississippi Delta region. And so the Mississippi Delta region is not just the state of Mississippi and the Delta that we have there, which has been near and dear to my heart. I just relocated here from Mississippi, where I did a lot of work up on the Delta of Mississippi. But the Mississippi Delta truly encompasses a wide range of territory in Arkansas, Louisiana, Mississippi, and Tennessee. So there's a substantial percentage of counties in all of these states that don't have a single hospital or birth center with obstetric providers. All of these states are also ranking low on other potential contributors to maternal mortality. So some of the things that they're seeing is that within this Mississippi Delta region, there's lower rates of postpartum depression screening, there's higher rates of low-risk cesarean births, and that there's higher numbers of uninsured rates prior to pregnancy. The other thing that was really highlighted by the Commonwealth Fund state scorecard is that the maternal mortality rate nearly doubled between 2018 and 2022, with the rates for Black and American Indian and Alaska Native women increasing the most. So you can see that huge spike, which of course we all very much remember what was going on in that period of time. And the COVID-19 epidemic certainly had a significant effect, not just due to the infection itself that the women were seeing the effects of, but certainly also due to the limits in access to care and other things that were associated with the pandemic. And while these are national numbers, the numbers here in Arkansas that I've been able to look and review very much mirrored this as well. So how are we doing here in Arkansas? So the 2024 state scorecard from the Commonwealth Fund measured 32 different metrics across 3 different areas. Specifically, they looked at health outcomes, healthcare quality and prevention, and then coverage, access, and affordability. And you can see here in the map that the top performing states are the lightest shade of the gray-blue color. And then as you go down, the darkest shades are the bottom performing states. And in 2024, Arkansas ranked 50th. And so we had some of the worst outcomes in the nation, which for me actually was kind of an eye-opening statistic, because having been in Mississippi for the last 15 years, I was very used to seeing my state of Mississippi in that place and holding the title of number 1 for maternal mortality, but Arkansas has taken that over as of this year. So before we go into some of the other epidemiology, I just wanted to briefly share some terminology, because it's really important to understand when we start talking about deaths of these women during and around their pregnancies. So when we look at the epidemiology, we talk a lot about pregnancy-associated death. So that's the death of a woman while she is pregnant or within 1 year of the end of her pregnancy, regardless of the cause. So it does not have to be directly related. There's also pregnancy-related death. So that is the death of a woman either while she is pregnant or within 1 year of the end of the pregnancy from any cause that is related to or that has been aggravated by the pregnancy or its management. So those are things that we think about, like, preeclampsia, postpartum hemorrhage, things that are just directly related to the pregnancy itself. The death would not have occurred if the woman had not been pregnant. And then there's pregnancy-associated but not related deaths. And so these are the deaths of women that occur while they're pregnant or within 1 year of the end of the pregnancy from a cause that's not at all related to the pregnancy. So one of the classic examples I see with this and share is a woman who was killed in a motor vehicle collision. So unfortunately, every year, we see women who are pregnant that die in motor vehicle collisions. And so their death is associated and has occurred during their pregnancy, but it was not at all related to the pregnancy itself. So the most recent data that we have actually came out from the Arkansas Maternal Mortality Review Committee in their 2024 report. But that report actually reflected back and looked at statistics from 2018 to 2021. So in that period of time, when they were reviewing the data, there had been 144,405 live births in the state of Arkansas. So in that time, there were 141 pregnancy-associated deaths. There were 59 pregnancy-related deaths, and then 61 pregnancy-associated but not related deaths, and 21 pregnancy-associated deaths that they were unable to determine the relatedness of the death. So the thing that is staggering about the statistic is that when they looked at the all causes of death, they determined that 95% of them were preventable. And so to me, this is one of those statistics that is overwhelming and is why I do what I do. If I think about 100 women in my mind that are pregnant mothers that are looking forward to the birth of their baby, and we lose all 100 of them, 95 of them did not have to die. There are things that we could have done to prevent those deaths. And so that's why I've really dedicated so much of my career to this topic, because I don't want to have to tell any more families that they have lost those mothers unnecessarily. So if we talk about the leading causes of pregnancy-related deaths here in the state of Arkansas, as determined by the Arkansas Maternal Mortality Review Committee, again, looking at the data from 2018 to 2021, the leading causes were infection, cardiomyopathy, cardiovascular conditions, hypertensive disorders of pregnancy, and then certainly last but not least is hemorrhage. So what really strikes me about this list is that 3 out of the 5 are related to cardiovascular health. And so that is something that we already see a significant number of women in our state affected by. And so a lot of their outcomes are directly related to ties in those areas. The other thing that I always like to really look at and point out is the timing of maternal death. So again, looking at that data, they broke it into 4 different categories. So deaths that occurred during pregnancy, deaths that occurred on the day of delivery, and then the other 3 categories were postpartum time period. So the first was in the first 1 to 6 days postpartum. Then they looked at 7 to 42 days postpartum. And then they looked at 43 days to the end of that first postpartum year. And what is really striking to me is that in all of the cases of pregnancy related, as well as pregnancy associated but not related, and pregnancy associated where they were unable to determine relatedness, the majority of these deaths were occurring in that window of time that was beyond the 43rd day postpartum. So the women are not dying during their pregnancy in the majority. The majority are not dying on the day of their delivery or even within that first 6 weeks postpartum, which are really the opportunities that for the majority of these women that they're at touch points where they're seeing physicians or other healthcare providers. They're dying beyond that 6-week postpartum visit. And so that to me is a really staggering statistic as well. So it's important to understand too the payment source for pregnancy-related deaths that occurred after delivery. 54% of those women had about 7% of them had a self-pay status, and then 39% had private insurance. So again, the majority were on Medicaid, which in many states offers postpartum benefits up to 6 weeks postpartum, but in many states is not extending that coverage beyond the 6-week point to the end of the first year. So if we look geographically here at the state of Arkansas to see where those pregnancy-related deaths occur, you'll see these numbers. And so in central Arkansas, which of course right there in the Little Rock area, they had the lowest rate of pregnancy-related deaths with 19.4 deaths per 100,000 live births. And then as you move out into the 4 corners of the state, those numbers rise dramatically, with our highest number of deaths being seen in Southwest Arkansas And then numbers very close between Northwest and Southeast Arkansas. The best outcomes are being seen up in Northeast Arkansas. So we talk a lot about maternal vulnerability and maternal vulnerability index. And so this is again the state of Arkansas, and the very high vulnerability areas are represented by the darkest areas on the map. And so this is something that I also like to try to explain to people, that outcomes really do get closely tied to zip codes. I can tell a woman if she has higher or lower risk simply by her address and where she lives. And so it's really important to understand that. And what you'll see here, the very high areas are the darkest areas, which is a majority of our state. So we know that birthing people here in Arkansas are most vulnerable to poor outcomes due to two factors. The first is their socioeconomic determinants, where we see significant disparities, as well as the physical health of the mother. So what can we do to try to make a change? What are some possible solutions to the maternal health crisis? Well, we know now statistically that most pregnancy-related deaths are preventable. And so it really takes a preventive strategy. And so prevention requires addressing three major things. The first being cardiovascular conditions. Like I said, 3 out of the 5 leading causes of death in women are related to cardiovascular conditions. And so really tackling that is got to be key. The next is mental health. We're seeing a significant rise in the number of women that we're losing in and around their pregnancy, and particularly in the postpartum period, related to postpartum depression that's not being recognized and treated, and seeing an increased rate of suicides in these mothers. And then certainly, last but not least, is the health disparities that we are seeing. And the emphasis there is going to be on really trying to bring equity to those mothers. So, what are some lessons that we learned from the scorecard? Well, the scorecard showed us several things. And when we looked at the states that had the lowest rates of maternal mortality, we saw several things that they all had in common. The first was that they had fewer uninsured women between the ages of 19 and 64. They had access to more maternity care providers. They had fewer women with no prenatal care, and they had fewer women with no postpartum checkups. So, what can we do? Well, very fortunately, here in the state of Arkansas, we have seen Medicaid expansion. There are still a few states in the nation that have not done that. That was one of the things in Mississippi that we had not yet done. But beyond Medicaid expansion, specifically looking at the needs of these women, is an effort to extend Medicaid postpartum coverage. And so here in Arkansas, there has still been no action on this. And so we've not extended that Medicaid postpartum coverage to the first year. And so, as I shared with you, those statistics, the majority of our women that we're losing due to deaths related to their pregnancies and even associated deaths are happening in that window. So it's happening in a window of time where women that have Medicaid no longer have coverage related to this. And so extending that Medicaid postpartum coverage is really going to be critical. The other is the access to care. And so we know that many communities in the United States have few or no clinicians that are providing maternity care services. And so that we know without doubt is contributing to the national maternal and infant mortality rate, and is why it is so much higher than in comparable developed countries. So the March of Dimes has done a lot of work in this arena, and they have defined maternity care deserts as counties that have no hospitals providing obstetric care and no practicing obstetrician gynecologist or certified nurse midwives. Now, the thing that always strikes me about the definition, as a family physician myself, and as a family physician who did obstetrics and delivered babies for a lot of years, is that they have chosen within this MCD definition to exclude the thousands of family practice physicians who are providing maternity care, and much of that is particularly being done in rural areas. So here's a map, again, that is a few years old, but that is dated back to 2021, showing the maternity care deserts and showing obstetric care clinicians by specialty in the U.S. So the areas that are very dark with the hatched line are where only family physicians are delivering. And then in the lighter gray shaded areas, there's family physicians and OBGYNs or certified nurse midwives. And then in the areas that are white entirely, it's only OBGYNs or certified nurse midwives. So you can see, looking at the state of Arkansas, first off, that much of our state has the gray hatched line. So the majority of our state is considered maternity care desert territory. And then you can see there's only 3 areas that have the dark hatched lines showing the places where only FPs are providing the care. So if you look at that maternity care desert map and overlay it with this, it makes a lot of sense. So currently, as of 2025 data, there's only 33 hospitals in the state of Arkansas that are providing labor and delivery services. And so amongst our state's rural hospitals, 60% of them now, or the majority, are no longer offering these services. And so that is why we have such a large territory that's really considered to be within a maternity care desert. So if you look at this and look at those maternity care deserts, you'll see that they're reflected by the places that did not have those birthing centers. And so we have, again, the darkest shaded counties here have access to maternity care. But then as the colors go lighter, it becomes moderate to low, and then finally a true maternity care desert. And you can see a significant portion of our state has no access to care at all. So I took a little bit of a dive into seeing who is delivering babies here in the state. Like I said, I had just recently moved from Mississippi, where at the time when I left, Mississippi only had 4 family physicians that were delivering babies. There was only a handful of midwives, and the majority were being delivered by OBGYN physicians. So here in the state of Arkansas, the most recent statistics I found were from 2022. And it showed that just over 88% of delivering providers were physicians. Just over 7% were lay midwives, and then 1.7% were certified nurse midwives. Now, when I looked at the statistics that broke down the physicians, I found that nearly 82% of those physicians were OBGYN physicians. 12.7% were family physicians, and 5.5% were other physicians, which you may ask yourself, if it's not an OBGYN or a family physician, who are those other physicians out there delivering babies? And while certainly the data that I looked at did not define those individuals, just from my past experience, anecdotally, I will tell you that oftentimes they're general surgeons. When I was practicing back in Missouri, in a very rural community, our general surgeon was on backup call for us. To where certainly if a C-section had to be done and we needed somebody to come in and help, our general surgeon came in and delivered those babies. And even back where I was in Mississippi, we only had 2 counties where family physicians were still delivering, but in one of those cases, at least, I know there was a general surgeon who was also helping back them up and was coming in to do some deliveries. So that would be my guess, is that the surgeons are a significant portion, at least, of the 5.5%. So the family medicine with obstetrics piece to me is a really critical piece at looking at a possible solution. So we know statistically nationwide that family physicians deliver babies in more than 40% of all U.S. counties, and more than 52.4% of those counties were located in non-metropolitan areas. And we know too from the national statistics that family physicians are the sole maternity care clinicians delivering babies in 181 maternity care deserts, so about 16% of all maternity care deserts. And yet, if you look here at our statistics, we have fewer doing it here in the state of Arkansas, where it's so critical that we have people out there trained to provide this care. So one of the things that I think is a possible solution to this is the development of FMOB fellowships. And so certainly while the ACGME accreditation requirements state that all family physicians in training who are coming out for board certification should have minimum competencies in obstetrics and providing that care, we're certainly seeing that there are less and less physicians that are coming out of family medicine residency training, feeling comfortable and confident that they have those competent skills, and therefore they're not choosing to do this in practice. And so the ability to obtain additional training through an FMOB fellowship is really critical for many family physicians who want to provide this care. And so I looked really just here in our area in that Mississippi Delta region, and then I did add Alabama and Louisiana to it since they are fairly nearby states, to look and see how many FMOB fellowships. And it really struck me because in Tennessee there were 6, Alabama had 5. Arkansas has 0. It was interesting because the statistics I found actually showed 1. And so I did a little bit deeper digging to find that the one that was listed in the National Directory of FMOB Fellowships was actually located right there in Fort Smith. But I actually spoke to the physician who had been the fellowship director there and learned that fellowship had shuttered and was no longer taking fellows. So Arkansas is back down to 0. Mississippi has 1, which I'm very proud to say was the one that I helped start and launch this past year with some of our strategic partners, working with the Easy Health Net Family Medicine Residency Program. So we have 1 in Mississippi there, but Louisiana also has 0. They had 1 several years back at LSU, but again, it has shuttered and is no longer providing training. So another opportunity to increase the number of providers giving this service and care is to look at the midwives. So here in the state of Arkansas, there are a total of 53 midwives based upon the most recent statistics that were collected in February of 2025. So of those 53 midwives, 21 of them were certified nurse midwives and 32 were lay midwives. And so you can see again the dramatic disparity in those numbers compared to some of our surrounding states who have significantly lower rates of maternal mortality. I mean, if you look just to our north in Missouri, there's 149. If you look just to our east over there in Tennessee, there's 349. Texas, that's 649. So that is another area that we can certainly look to as a possible solution to increase the number of midwives that are practicing here in the state. So I thought it was important to really kind of look at and address the 2 types of midwives that we have here in Arkansas. So they put them into 2 different categories here in the state. The first is the certified nurse midwife, or CNM, and the other is the licensed lay midwife, or LLM. So our certified nurse midwives here in the state are advanced practice registered nurses that have a master's or other doctoral degree in midwifery and have been licensed by the Arkansas State Board of Nursing. This is in comparison to our licensed lay midwives who are certified professional midwives that are licensed through the Arkansas Department of Health. So if you look at the scope of practice for these 2 types of midwives, the certified nurse midwives provide a full scope of care, including primary care and gynecologic services, as well as family planning, preconception care, care throughout the pregnancy and childbirth, and then the postpartum period. They also will often provide care for the normal newborn during the first 28 days of life. So these midwives are practicing in hospitals, licensed birthing centers, as well as attending home deliveries, as long as they have additional proof of collaboration with the transferring hospital or physician. If they're doing home births. And so the licensed lay midwife, in comparison, provides care for low-risk pregnancies and births. But the requirements that they have are significantly less. So as I mentioned, certified nurse midwives are advanced practice nurses that have at least a master's or doctoral degree, versus a licensed lay midwife must have a high school diploma or its equivalent and then be certified by the North American Registry of Midwives by passing a licensing exam administered by the Arkansas Department of Health. So they oftentimes provide a more limited scope of practice. The other thing I think that we can address is looking specifically at our rural communities. And so this is the Arkansas population based upon U.S. Census data back in 2024. And you can see that the majority of our state is rural by definition. And so if we look specifically at Arkansas rural healthcare facilities, you'll see them outlined here. And so we have 27 critical access hospitals in the state, 150 rural health clinics, 21 short-term PPS hospitals, 4 rural emergency hospitals, and then 161 federally qualified health centers scattered throughout our state. And so, what I like to point up about this statistic is that in our rural communities, these are the places where many women are going to seek evaluation, especially in that postpartum period. Many of them will travel into the more urban areas where the OBGYNs are located for prenatal care, although sometimes that's again limited access for a variety of reasons, such as transportation. But they're oftentimes able to get there for some of their prenatal care and for their deliveries, but the postpartum care can be a really struggle. And so this graphic is showing you the median number of minutes that these women are having to travel to a delivery facility in 2022 based upon their county and how things have changed. So it picked up 2 counties in particular. So in Columbia County, the median minutes that were traveled by Columbia County residents increased fourfold from 2016 to 2022. So that was the third highest increase in any county. So it went from 11 minutes of travel time in 2016 to 45 minutes of travel time in 2022, which if you're a pregnant mother in labor or having some other sort of obstetric emergency, to have to travel 45 minutes is a serious game changer in your potential outcome. And so we're losing a lot of these mothers related to that. So if you look at why, back in 2016, Magnolia Regional Medical Center delivered around 68% of the births in the county, so the majority. But the hospital's labor and delivery unit closed in 2021. And so the next closest birthing hospital for the majority of those mothers became 52 minutes away. So they're having to travel a long distance. The other comparison is over in Phillips County, where the median minutes traveled by Phillips County residents increased eightfold from 2016 to 2022. So that was the highest increase in any county. And so the median travel time had been for those mothers 6 minutes back in 2016, and now it's up to 51 minutes in 2022. So again, in 2016, Heller Regional Medical Center was delivering about 65% of the births in the county. But the hospital's labor and delivery unit closed in 2020. So that made the next closest birthing hospital for the majority of these mothers to be 47 minutes away. So if we look at all of the counties combined as an aggregate, the statewide median minutes traveled was 16. But if you look at the top and bottom numbers there, 2 minutes was the closest, up to 73 minutes. So one of the things I always talk about when I talk about this is not just the distance that's being traveled, but also some of the other downstream effects from that. And so oftentimes mothers that are living in these rural communities that know that they're such a significant distance away from a delivery hospital are not getting in their private vehicles and going by private vehicle. Now, some of them are, certainly it happens, but oftentimes many of those women are picking up the phone and calling 911, and EMS is responding and coming to transport those women, which certainly has effects on healthcare, even beyond the maternal mothers. So in many of our rural counties, not just here in Arkansas, but certainly around the country, there's a shortage of EMS providers. And so if you're living in a rural community that maybe only has a couple of ambulances in service at any point in time, and you take one of those ambulances out of service because they're transporting a mother, 45 minutes to an hour to get to a facility, that ambulance is out of service for the county for others that may need it for things like, their heart attack or their stroke, or they've been in a horrific car accident on a highway or interstate. And while we're seeing this number, the time taken to travel go up dramatically, the impact on EMS is even more than that, because oftentimes these ambulances are not just out of service for the 45 minutes to an hour to travel to the delivering hospital, but depending upon the hospital, wait times for these EMS providers can be up to 2 hours. They're waiting to offload their patients and then get back on the road. And so then if they're another hour back to their county, we're seeing some of these ambulances out of service for the county for 2 to 4 hours at a time. And so certainly we're seeing impacts with with things like those individuals that are needing transport for other life-threatening conditions as well. So in 2023, there was a survey done by the ARPQC of Arkansas emergency departments, and 55 facilities responded. And so, again, many of these are rural hospitals. And what they saw was that 68% of them had an urgent transport of a pregnant or postpartum patient in the past year. 41% of them considered having a close call or unanticipated adverse birth outcome in the past year. And 20% conducted simulations or drills for an obstetric emergency in the past 2 years. Now, what's significant to me in these statistics is that the majority of them had an urgent transport that they had to do either for a pregnant or postpartum patient. Almost half of them have close calls or unanticipated adverse birth outcomes. And yet only 20% of them were conducting simulations or drills for obstetric emergencies. And so this is another area that we have that we can focus on to make improvements and try to seek a solution for these mothers and their babies. So training is critical for these rural emergency departments, and I would say also their associated EMS services. So the Arkansas Perinatal Quality Collaborative has now made an opportunity to any Arkansas emergency department to host a free obstetric emergency simulation training at their facility. So they are offering in-person simulation trainings that are led by obstetricians and include classroom learning sessions followed by simulations that utilize a mannequin to provide realistic hands-on experience for the training participants. And so the ARPQC is currently offering these trainings that are specifically designed for emergency department staff on these pregnancy-related hypertensive emergencies, as well as precipitous births and hemorrhages. And they've just recently begun piloting an obstetric emergency management overview for first responders. Now, I wasn't able to find any statistics on outcomes related to their trainings, but I will tell you in the state of Mississippi, where I just came, the University of Mississippi Medical Center had begun offering very similar trainings to rural hospitals and rural EMS. And it was being funded through a grant. So there was ongoing data being collected and research, and they were seeing significant improvements in outcomes related to these trainings. So since we know that about 20% of the hospitals are currently getting simulation and training, we have a huge room for improvement here to get this training out. And I think part of that is just making facilities know that it's available to them. And so the ARQBC Learning Center is also offering online courses that are specifically designed for inpatient obstetric and emergency department staff based upon nationally recognized evidence-based protocols and guidelines. So even if they're not able to host something live and in person, they can offer those free online courses to their staff to help them prepare for disease that they know certainly they will be seeing. The last thing that I wanted to highlight as an opportunity for this training is the Advanced Life Support and Obstetrics course, or also. I think most individuals that work within healthcare facilities are very familiar with BCLS and ACLS and PALS, but at least from my experience, many of them have never heard of also. And so this is an evidence-based interprofessional multidisciplinary training program that was created by the American Academy of Family Physicians specifically to equip the entire pregnancy care team with the skills that they need to effectively manage obstetric emergencies. And so also is a very comprehensive course that encourages a standardized team-based approach amongst not just physicians and residents, but also nurse midwives, registered nurses, and other members of the pregnancy care team that will help improve patient safety and positively affect maternal outcomes. And so I think offering this opportunity to facilities and their healthcare professionals is also very critical. And I'm not seeing it utilized near as much as I would like to. And I think it can make a great impact as well. So at the end of my slide set here, I did include all the references for my presentation, just so that everyone would have them if they wanted to look at detail. And then that concludes my presentation. So I will stop sharing my screen so I can see everyone again.
Thank you, Dr. Stevens. We do have a couple of questions. Regarding doulas, in Oklahoma, there's been significant effort to integrate doulas, especially in underserved communities and for underrepresented populations, to enhance outcomes for maternal health. Given the similarities, certainly with the two poorest counties in Oklahoma being adjacent to the Fort Smith Van Buren area, has Arkansas experienced a comparable movement to incorporate doulas to address the shortage of practitioners?
So I will have to admit, being so new to the state of Arkansas, I am not aware of a great effort. But what I will tell you is in all of the research that I was doing preparing for this, I also didn't see anything really speaking about doulas to any significant extent here in the state of Arkansas. But I agree, doulas can have a tremendous impact. Yeah. Okay. So I was making sure you can still hear me on my side. It said that I was on hold. Um, so I think doulas certainly have a very important role that they can play in supporting the pregnancy care team and supporting these pregnant mothers. So I would love to see it be something that was really advanced and integrated, especially like was mentioned in some of these communities where we're seeing some of the most significant disparities.
Okay. Another question deals with social determinants of health. We know that education is vital to successfully reduce and prevent maternal mortality and morbidity. With regard to willful ignorance, how much of a role do you believe that even though people refuse to do better when they know better, how much of a role does that play on the statistics that have been presented? Did we did we lose you? You were muted, Carol. We saw you quickly, so
Okay, we're troubleshooting.
all
So
right.
for some reason, it kicked me entirely out and won't let me log back on. So I moved over to a new laptop, which is
No,
seeming to
no
work.
problem.
So I'm back. I don't know how much of my answer you heard though. Um,
We didn't hear any. And do you need me to repeat the question about knowing better but not doing better?
okay, I'm gonna work to see. Let's see, because now I can't hear you. Can you hear me okay?
Yes, ma'am.
Think so. So I'll just keep talking since I think you can hear me. Um, as I was saying, I'm new enough in Arkansas that I'm not very familiar with all the efforts that are being promoted for the integration of doulas. Um, but in doing all of my research, preparing for the presentation, I certainly did not see much in the data that I was looking at and in the reports and things throughout, all the organizations that are really working hard in this arena here in the state. I will say that I think it's very important. And so that was something I was very involved with back in the state of Mississippi in the work that I was doing. And we were looking at ways to integrate doulas into our pregnancy care teams, especially in a lot of our rural communities, as well as our other communities that were facing some of those significant disparities. And we were seeing great success in their involvement and in the outcomes and the improvements we were seeing with those women and their babies.
Great, thank you. One other question, it's a mentoring question. And do you think there's a way for underperforming states like the Gulf Coast states to work with states that are performing well in terms of the 30 plus factors measured in maternal health care? Do you think there's a way to partner up with a poor performing state and high performing state?
Muted. Can you ask that question again? It like went out when you were speaking.
Sure. Do you think there's a way for underperforming states to be mentored by states that are performing well in terms of maternal health care?
So that's a great question. I think there is. I think it can be challenging. I think, that was part of the idea between the Commonwealth Fund and looking at their statistics was looking to see what did high performing states look like and what did low performing states look like. And so we were certainly able to identify characteristics of both states. And so we certainly knew what seemed to be at least working in the states that were doing well. And so um, I would like to think it would be easy to adopt a lot of those, but we know certainly it's not always, because sometimes um, there's a lot of other things involved. And so I do think there's room, though, and I do think, and this is just again personally speaking, but I think there's also a lot of room for collaboration even between the states that are struggling. And so that is one thing that I certainly learned even just with the move that I made recently is, you know, there are a lot of us in the state of Mississippi that were working incredibly hard and devoting a significant portion of our careers to this topic. And yet we were working kind of in the silo of the state. And, I was at an event actually not too long ago, and I don't know if it was by intention or just coincidence, but we were assigned seating at tables for the event, and it was a medical conference. And at the table that I was seated at, they also had sat somebody from Arkansas, from UAMS, and then somebody from Louisiana from LSU. None of the three of us had ever met each other. We were all working in the same arenas in our own states. And we all started kind of comparing notes because we all were working on the Mississippi Delta. I, of course, the Mississippi Delta in Mississippi, but they on the Mississippi Delta by definition within their states. And so what we saw was we were running into a lot of the same challenges and struggles. And so we really had a long discussion about, if we were able within these states that are seeing such challenges, able to combine our efforts, if there would be enough more power with that collaboration to really move the needle forward. And so I think that's the other thing. I think we can learn from the states doing well, but I think there's even a lot of room for growth and improvement just by collaborating with other states that are seeing some of the same challenges, because we're all trying to fight a lot of the same battles, and by collectively putting our efforts and probably more importantly our resources together, hopefully we could move that needle a lot farther than any one of us is doing on our own.
Well, thank you. And thank you for your time today, and for you and Carol joining in, even though you're doubly committed. Thank you everyone for joining. We will pick this up again tomorrow at noon for our last in our four sessions series where Dr. Moriali will join us and present. Have a good rest of the day, and thanks again for your time and participation.